everyone. Welcome to Preemie Chats. Preemie Chats is our weekly educational sessions for healthcare providers and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I am a Preemie parent and Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led charitable organization that helps families in and after the NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching this session live today, please bring your voice to this table. Leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching from. And today we're going to talk about cerebral palsy. There are more than 17 million people across the world living with cerebral palsy. Another 350 million people are closely connected to a child or adult with cerebral palsy or CP. CP is a physical disability that affects movement and posture. Many people with cerebral palsy have other related vision, hearing, communications, and mobility needs. Its impact can range from a weakness in one hand to almost a complete lack of voluntary movement. It is a complex disability, and babies born preterm have a higher probability of having CP. October 6th is World Cerebral Palsy Day. It is a global movement that is started in 2012. It aims to bring together people living with cerebral palsy, their families, supporters, and organizations from over 100 countries, all with the aim to ensure a future in which children and adults with cerebral palsy have the same rights, access, and opportunities as anyone else in our society. In this Preemie Chat today, Dr. Karen Thomas will talk about communication in the early identification of cerebral palsy, to explore changes in the approach to the diagnosis of CP, and how this might impact a family's experience in the Neonatal Follow Up Clinic. She will share background information about cerebral palsy in children born prematurely, assessments that might be completed in the baby's developmental follow-up journey. We will also meet author Desiree Da Costa, who will talk about her children's book, All About Me and Cerebral Palsy, a story based on her own experience living with CP. And I have here joining me live today, Desiree. She's in Toronto, and she is an accomplished developmental service worker with a keen interest in pediatric healthcare and author of a children's book, All About Me and Cerebral Palsy. Desiree, thank you so much for joining us here today.
Oh, thank you, Fabiana, for having me. I'm super excited to be here.
So we are very excited too. It's a very special Friday. Sunday is World CP Day, and I couldn't have a better guest than you, a big advocate for our kids in the community. But I want you to share why you're here, because our community, as you know, is a lot of families of babies who were born preterm, and many of them have CP. So they are here joining us live. They might have a lot of questions. And I think you bring so much hope for families who are still on the early days of the diagnosis and learning how to navigate in this new world.
Yeah, thank you so much. I'm excited
So
to
share
share
a
a little
little
bit
bit
about
of,
this.
yes, so share a little bit of your story with us. What do you know about you being a preterm baby, and how was the first year at home as far as your mom tells you all the stories? Because obviously you don't remember.
Yeah, so I was born at 30 weeks, at just under 4 pounds. And I have a very interesting birth story from what my mom tells me is that um, I was born at the time that there was a nurses' strike in Ontario. And, with the nurses' strike, there was limited resources. So either there wouldn't be a bed for my mom in local Toronto hospitals or an incubator for me. Incubator would be necessary because I was preterm. So I actually had to be born in Hamilton at McMaster. So quite an interesting story and journey. where I spent about a few weeks there at the NICU at McMaster, and then eventually transferred to Toronto for about another month at a Toronto hospital.
So you did have a NICU stay, and now you're 30 years old and you have accomplished so much. But what do you know about your first year home that your mom tells you or your family tells you in terms of your development? How everything came into place for your family?
I think the first months were pretty normal, but then eventually, as I started to grow, I wasn't meeting the developmental milestones, particularly sitting up. And I have two older sisters, so it definitely served as an example for my mom of like things I should be doing at a certain age. And and then from there, go to a pediatrician, and where they do an assessment, and then all the MRI and so on. So a lot of medical uh, investigations. But then I got the CP diagnosis about 2 years old.
So do you know how that impacted your family life at the time of the diagnosis? Does your mom and your family talk to you about it? How that was for them?
I think I gather that, it's something very different. My sisters are typically developing. So obviously a challenge, something you get a diagnosis. I bet there were, a lot of unknowns and a little bit scary, right? Um, so you just kind of have to take things one day at a time.
Absolutely. So tell us about your experience growing up with cerebral palsy.
Yeah, I think, everybody asks me that. But I like to say that it was pretty normal because I don't know anything else. One thing that really sticks out for me is I think that CP, in my experience, I feel like I grew up very fast because I was always very in tune and understood everything that was happening around me, going to appointments and doing lots of therapies. You get thrown into a world where maybe typically developing children are not exposed to. And these are obviously very challenging things, going through surgeries and countless hours of therapy. So in a way, I feel like I've matured um, faster than typical kids because I'm given such challenges to have to, navigate.
No, I totally see that because, as you know, my son Gabriel also has cerebral palsy, and you know Gabriel well
I
because he
do.
goes to Bloorview, and he's pretty much your buddy at Bloorview. And yeah, he's 12, and I feel that he is mature because he goes through so much, and he's the one always advocating for him when you go to appointments. He's the one who shares his story and what is happening to him. And I agree, it is you have to mature a little faster, I think, because of those stories, the experience that we go through. But how was for you at school? We are talking about, you're adult now. You have used What were your experience in the school years in terms of inclusion? How the kids treated you? Did they treat you differently? Were you part of all the activities in school? Because I think a lot of parents are still advocating for that, and this is a lot of struggle in the school for kids with CP. What was your experience with that?
So I started at the Bloorview School, the Integrated and Education Therapy Program that runs from kindergarten to grade 1, which is exclusively for Holland Bloorview clients and kids with disabilities. So I would say that is my favoriteest school. That was the best experience I had because it's such an inclusive school. And I think it's really special. People will say, oh, everybody's different. But truly, everybody at Bloorview is different and everybody has their own uniqueness. And I really feel like it was such an environment where everybody could thrive. But then after Bloorview School in grade 2, I went to a mainstream school. It was definitely very different. It was a big adjustment for me, just from aside from like classmates, just the actual physical space of, let's say at Bloorview, the class has 8 students and one EA or one teacher, 2 EAs. And now you're in a big classroom with lots of kids with one teacher and maybe you have an EA. So the actual physical setting was very different for me. I didn't get a chance to go visit before my first day, so it was a little shocking experience. If I was able to go back, I would say maybe to have a visit or even a day at my new school, just to kind of test the waters of what it would feel like to be there every day. Um, Everyone was super nice. Luckily, I didn't experience like very overt bullying, but definitely felt different because I was going from such an environment where, everybody had their own needs and did things in their own ways. Where at the mainstream school, I felt like I really kind of stuck out. So that was a little bit hard.
Oh, I bet you was. But it's such a great tip for parents, right? To take a kid on a tour before the school starts. And I feel this applies to so many children, right? Because there's
Yes.
anxiety to start a new school, a big school, but particularly for kids with CP, I think is very important. Yes, to get adjusted to a new environment, especially kids like you who went to a very specialized school in the first few years where there's so much support, and now you're just big school in this whole new world. Such a great tip for parents listening to us today. So tell us about your career, because I feel you, because we talked to you before, and I felt that, okay, you were geared towards this career that you chose because of your experiences. So tell us a little bit about that. What's your choice of career and the place that you work today with? You work with a lot of children with many different disabilities.
Yeah, so I studied developmental service work, which is like a general um, diploma program to work in a variety of different settings with people with disabilities. One being as an educational assistant. So that was my main goal. And that's actually where I met Gabriel, was when I was doing my student placement at Bloorview School in an educational assistant type role. But now I actually work at Holland Bloorview doing medical admin side, but client facing, doing all ambulatory care registration. So I see lots of kids and families, and it's a great, I think one of the greatest joys about my job is that part of it is to make the children feel welcome and happy before their appointments.
Oh, and you absolutely do that. It's such a pleasure when we come for registration and see you always smile, interact with the children. It does make a huge difference. But I also feel like seeing you and other people with disabilities working at the hospital where parents come with a very fresh diagnosis, and we feel what is so overwhelming. And sometimes we have no hope for the future. And you see you working there, living a full life, happy. It gives us so much hope, right? That the future is good for our children, no matter the diagnosis. And they are there doing their thing, living a full life. And I love that. So I think that is the reason why you also wrote a book. So let's talk about your book, um, because it's such a beautiful book for families with kids with CP, but also for kids to see themselves represented. So why did you write the book, and where this idea came from?
So this is my book all about me and cerebral palsy. I wrote it because kind of like towards the end of COVID, and one day I was bored and I said, I'm going to write a children's book. I know nothing about writing children's book, but I had an idea, and I wrote it in about 2, 3 hours. And then I said to myself, I'm going to save this because one day something will come out of it. Um, and then I took about a year until I got in touch with a publisher, and then about 10 months of the work of the production. So definitely a long road. I'm super happy that it's out and people can enjoy it. It was released earlier this year. The idea is actually based on my time at Bloorview School. So as I mentioned before, the program goes until grade one, and part of the grade one classroom project is for every student to create an all about me book about themselves to bring to their new schools at second grade. So I still have my original all about me book that I made at that time. But I got the idea from there. And in the book, in this book that I published, we follow the main character's name is Gabriella, and she shares about herself and her her experience with CP, because everybody's experience with CP will be different. And we could see here in this photo here, the classroom picture. It's super special because the person in the middle, that's the teacher, and that's based on Bloorview school teacher Paul, and he's the best teacher ever. And I told him about the book, and then I wanted to put him in the book, and there he is, and he agreed to and was super happy about it.
Yes, Gabriel was very lucky to have Paul as a teacher as well when he was at Bloorview, and it's such a difference that he makes in kids' lives. So what was the influence of him in your life with those years at Bloorview?
I just think, he's just a genuine, nice person, and he's really passionate about teaching and really making sure that every student can thrive and do their best. And there's really nobody like him. And when we think of, I think it's a universal experience when people know Bloorview School, and they also know and think of Paul. He's such a dynamic individual that just leaves a mark on everybody, a positive mark.
Absolutely. So if people want to get hold of your book, can you tell us where people can find your book, where they can purchase the book?
Sure. You can visit my website, allaboutme and cerebralpalsy.ca. There's all the links to all the online stores that carries the book. It's available in Canada and the US. So for example, Amazon, Indigo, Barnes & Noble. And you can also follow me on my Instagram, allaboutme and cerebral palsy.
So let me share the link here so people can follow you. Desiree, as we are talking today with parents whose kids might have a new diagnosis of CP, what do you want them to know?
That there's hope. Take one day at a time. And one thing I didn't really mention, but I'll mention it now. One thing that was so important, I think, for me was all the support that I did have medically. Not just medically, but I think when I speak of my experience at Holland Bloorview, they become, at least for me, like part of my family because they follow me for so long. And obviously, they've chosen these types of careers to be doctors or physios and whatnot. But I think their personalities and who they are as humans really, really shaped me and was really great support. So I think that as much as it seems daunting to navigate a world of CP in a medical world, I feel like everybody's there to support their patients and clients, which is really nice.
Oh, that is wonderful. Desiree, thank you so much for joining us here today, for sharing your story, your beautiful book, and I'm very grateful that you took the time to be with us.
Oh, I'm so happy. Thank you so much for having me.
Thank you. And our next guest today is Dr. Karen Thomas. She is an associate professor in the Department of Pediatrics at McMaster University. She's a neonatologist and developmental pediatrician in the Division of Neonatology, and it is a director of the Neonatal Follow Up Clinic at McMaster Children's Hospital. Her clinical and academic interests align with a research portfolio that centers around the early identification of neurodevelopmental differences among NICU graduates for the purposes of early intervention implementation. She leads a number of initiatives that aim to improve functional outcomes of children, including contributing to the early identification of cerebral palsy and autism spectrum disorder in this population. And I have here joining us live from Hamilton, Ontario, Dr. Karen Thomas. Thank you so much for being here with us today.
Thank you so much for having me. And thank you so much, Desiree, as well, for sharing your story and your journey with us. And in keeping with the theme of today's chat, I wanted to give a bit of an overview on some of the changes over the past few years in the work of CP diagnosis, as well as in the communication of this diagnosis with families. Over the next kind of half an hour or so, I wanted to review the neonatal follow-up guidelines and criteria and goals within the neonatal follow-up. So criteria for referral, and then in keeping with the goals of neonatal follow-up, as well as the definition and guidelines of CP and the neuroimaging and assessments and neonatal follow-up that you might experience if you are a parent kind of going through that journey, as well as kind of the communication within that realm and communicating an early diagnosis of cerebral palsy. So historically, the Neonatal Follow Up Clinic has been a system of monitoring outcomes, but that has evolved over time to include a number of different objectives. So one of them is following and assessing infants to improve things like guidelines and care that's provided for these populations. A second is providing information and education to parents and to families. A third is identifying early markers for possible future conditions. And then in some cases, providing longer term monitoring to address issues that may take longer to arise. Within the Neonatal Follow-Up Clinic, we see infants at different developmental touch points according to their corrected age and different provincial guidelines. So this is an infographic from the Canadian Premature Babies Foundation that helps families keep track of their progress in the Neonatal Follow-Up Clinic. And there are plenty of other resources related to the clinic and to neonatal follow-up that can be found on their website. In terms of referral criteria to neonatal follow-up, there are quite a few, but specific to this group and this population, if you're being followed by a tertiary care hospital, infants that are born at less than 30 weeks or less than 1,250 grams with different things like bronchopulmonary dysplasia or chronic lung disease, things like that, they will be referred automatically to a neonatal follow-up clinic in a tertiary care center. And there are plenty of other sort of children that may be followed for different types of conditions. At each of these developmental touch points leading up to graduation from the neonatal follow-up, different assessments are completed. And several of these assessments, especially those completed in some of the earliest visits, are to assess for the identification of cerebral palsy prior to graduation date. So what exactly is cerebral palsy? This is sort of the definition, but CP describes a group of permanent disorders of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. The motor disorders of CP are often accompanied by disturbances of different things like sensation, perception, communication, behavior, sometimes by epilepsy, and sometimes other musculoskeletal issues. The timing of injury is not clearly delineated, and neither is the age of confirmation of the diagnosis. For many years, there was this belief that a child needs to be at least 2 years of age to receive a diagnosis of CP. And this stems mainly from the fact that CP registers and things like that have been providing clear timelines on when children can be registered, which was typically around 2 years of age. That allowed enough time to rule out other progressive neurological disorders that would not be called CP prior to registration in some of these CP registers. But this can lead to a delay in diagnosis and often to a delay in providing some important interventions. So why is this particularly relevant to the preterm population? We know that children that are born preterm are at higher probability or likelihood of being diagnosed with CP, although the percentage of neonates is still quite low and does decrease with increasing gestational age. This is information from the Canadian Neonatal Follow-Up Network annual report. They release annual reports every year, and this was from 2022. As you can see, in that year of children evaluated at 23 weeks gestation, they're seen kind of at 18 to 24 months corrected age, around 13% had a diagnosis of CP, while at 28 weeks, this percentage decreased to about 5%. This graph also divides CP diagnoses into GMFCS level, which we're not going to get into much here, but is the gross motor function classification system. And that gives a sense of the degree of physical support required for these children. Just to give this slide a little bit of context as well, in the general population, the prevalence is about 2 to 2.5 per 1,000 individuals. And if we look at trends in CP rates over time from 2009 to 2019, we can see that CP rates did fall until around 2017, but have remained fairly stable since then. And in 2018, some of the restrictions around COVID maybe have biased some of this data towards seeing more children with CP, and that's potentially why we see a bit of a rise there in those 2 years. So we have the definition, but how do we actually diagnose cerebral palsy? When do we actually diagnose CP? Historically, a watchful waiting approach or a passive approach with respect to CP diagnosis has been taken. And this was often necessary due to the lack of specific assessments, neuroimaging, but there have been major advances in neonatal follow-up and early developmental testing batteries that are implemented in neonatal follow-up clinics, which we'll go through some of. But as a result, clinicians can now have access to more specific information to enable evidence-informed prognostication earlier on. On average, in Canada, CP diagnosis is made at around 18.9 plus or minus 12.8 months of age. And in 2017, international clinical practice guidelines were developed, and I'll review some of those, but they exist to identify and detect CP as early as 5 months in the higher probability infant group. So that would kind of fit in with the group of children that are seen in neonatal follow-up clinics. With that being said, then early diagnosis can prompt for referrals to evidence-based intervention at an age when the infant brain has the most neuroplastic potential. So recent studies show that specialists can diagnose CP as early as 6 months of age in some cases, and sometimes even earlier. In 2017, these international guidelines for early CP diagnosis and intervention were published, and they were backed by scientific experts as well as parents. And that early CP recognition is vital to provide infants with diagnostic-specific early intervention and surveillance, to optimize neuroplasticity and prevent complications, as well as to offer parents psychological and financial support where that might be available. CP is typically diagnosed, as I mentioned, between 12 to 24 months of age, and 86% of parents suspect that their child has CP before the clinical diagnosis is made. So these guidelines help to give us informed ways of making an early diagnosis of a high probability of cerebral palsy or a CP diagnosis at less than 5 months of age. And how do we do this? We do this through a number of different assessments with the addition sometimes of neuroimaging. The general movements assessment, and this is to kind of give you a sense of some assessments that may be done within the neonatal follow-up clinic at these different developmental touch points. So the general movements assessment is a powerful tool in predicting CP with an accuracy of 95 to 98%. Neurological examination is the Hammersmith Infant Neuro Examination, which also has good predictability and accuracy in the diagnosis of CP. And these can be combined potentially with neuroimaging, initially with cranial ultrasound, sometimes with MRI if needed. But in our premature population, sometimes neuroimaging is not even necessary. It's really through this concise history taking, review of medical history, neuroimaging if available, and completion of the general movements assessment and or the Hammersmith Infant Neuro Exam that an infant may be diagnosed with CP, or in some instances, a high probability of CP diagnosis at the discretion of the physician or the clinician. Once we have made a diagnosis of high probability of CP or a CP diagnosis, how do we then communicate this with families? So this is a quote from a report of the Hastings Center, and I find it just resonates with this topic. James Dubois in this report writes about how statements that are not intentionally malicious, but often careless, are remembered by patients and can cause pain for years later. And he wrote, communication during clinical encounters can cause great harm or great healing. And there truly are harms experienced when communication fails. So how do we communicate a diagnosis of CP? It's important to reference, for clinicians, to reference with families the NICU course or history, as well as any neuroimaging that's existed, and link that to an impact, the impact of injury that's observed by parents or evident on clinical assessment. We often caution families on the limitations and practitioners on the limitations of early prognostication. The diagnosis of CP, we know, represents a complex, emotionally charged journey for both healthcare professionals and for families. So the manner in which a CP diagnosis is communicated is really crucial. It can significantly shape the experiences and outcomes for all parties involved. So Dr. Paige Church and this group that I am proud to be involved with recently completed a review of the current existing literature to see if there were any themes relating to disclosing a diagnosis of high probability CP or of CP to families. This one was submitted at the time of creating this presentation and has been accepted for publication by Acta Pediatrica. So you guys should see that in the coming weeks or months. But we landed, on these several themes in that process of communication. One being timing, another setting and people, another content, approach, and follow-up. When we look at timing, historically, there's been some concerns of interruption to attachment with an early diagnosis. But in terms of timing, the literature overwhelmingly favors parental preference for a diagnosis of CP or high probability of CP or even possibility of CP as early as feasible. A lot of the literature has suggested that if a diagnosis of CP is even being considered, that it should be discussed with parents at that time. And of course, the uncertainty around that early diagnosis should also be highlighted if it does exist. In one of the studies that was reviewed, it was a study of parents of over 100 children, and the majority reported suspicions of differences in their development before ever receiving their diagnosis of CP. 44 of the mothers that were interviewed expressed feelings of things like anger related to those perceived delays in the diagnosis. Delays have also been found to lead to parental frustration and can, of course, hinder early intervention opportunities that are crucial for a child's development. Setting and people involved in that interaction was another theme that was prevalent in the literature around disclosing a diagnosis of CP. And the setting and individuals involved in that diagnosis, that diagnostic disclosure process are crucial. The preferred setting is one that's private and one that is without any interruptions. Parental satisfaction has also been associated with the presence of both parents or non-parental support, in addition to a single parent during the disclosure. And better disclosure experiences have been associated with a single diagnostic messenger. So often what's recommended by families or what's supported by families is a team approach with those that have completed the assessments, those individuals that know the child, but one single diagnostic messenger for clarity. As well, of course, to allow sufficient time for questions to be answered during that disclosure process. In terms of the content, the need for clinicians to be mentally prepared, to have factual preparation, environmental preparation is really recommended prior to the diagnostic disclosure. And extensive evidence documents the parental experience in the NICU being characterized by things like trauma, guilt, separation from their child, and stress. So critical to that diagnostic discussion is the need for assurance that the parents are not responsible for their child's preterm birth, subsequent challenges or differences in their development, and transparency around the findings. We have seen in the literature, and this literature review kind of goes over emphasizing value neutral and functional individualized observations. When we talk about value neutral language, we kind of think about attention to details in the use of language, and that being really, really important. So avoiding assigning value in any direction to the diagnosis of CP. So one example of this is the use of the word risk. So high risk CP, or there is a risk, a diagnosis of high risk of cerebral palsy. That intrinsically assigns value to the subsequent diagnosis to come. Parents have also articulated a preference for hearing information about the diagnosis of cerebral palsy in a way that is clear and direct. Satisfaction of parents has been related to the amount of information that they received and the content, suggesting that initially, perhaps more information is better than less, and explicitly addressing parental concerns is also extremely crucial and important. A fourth key theme in this review of the literature around communication of a CP diagnosis is the approach taken during the diagnostic disclosure. So things that have been underscored in approach are things like honesty, warmth, and sympathy, as well as the power of hope and encouragement, compassion, sensitivity, and support during this their moment. Parents have demonstrated a preference for simple, direct communication, avoiding being too general in their approach, and inviting of questions and response from families and parents. And something we sometimes may forget about in neonatal follow-up when our guidelines are to assess at these sort of different developmental touch points is what is our follow-up when making these diagnoses. So parents have emphasized the importance of follow-up and of resources, so ongoing support as well as information, follow-up appointments, as well as written information, written materials that they can take home and reflect upon, and of course, rapid referral to and follow-up with physiotherapy or any other services that may be helpful following diagnosis. So this is sort of what we're aiming to do next, and where the world of neonatal follow-up is looking towards is developing somewhat of a toolkit for that early communication in that early diagnosis of CP with families, with evidence that actually informs this practice and informs this toolkit, with the goals, going back to that Hastings Center report of contributing to healing and not to harm. I want to give a huge thank you to this group. This is the Hein Implementation and Teaching Working Group, who has worked towards early diagnosis of CP in general in pediatrics and specifically in neonatal follow-up, with early implementation of assessments that can contribute to that early diagnosis and the communication with families and other healthcare practitioners. So thank you so much to everyone listening, and absolutely would love to invite questions, discussion, or anything else.
Dr. Thomas, thank you so much for your presentation. It's very enlightening. Know what's happening in the neonatal follow-up clinics now is really great. And I have a lot of questions because, my son has CP. We did get a diagnosis on a neonatal follow-up clinic, and a lot of those new items are not in place on how to deliver the news to parents. But I want to start with the first question on this early identification. My time, which was 12 years ago, well, maybe 9 when he was diagnosed, we were referred to a center for therapies, for OT, PT, for all the therapies that my son needed. Now, but he was 2 years old at the time. So now, when you have this early identification, are families getting referred to services in the community? Are there services available for babies who are that early? If they are 6, 7 months, they are already accessing those early interventions that are so important for our babies, because you talk about neuroplasticity. I just wanted to unpack a little bit more of what is happening in the system now.
Yeah, and I think that there is so much variability and heterogeneity around that, like across this province, across the country, in terms of that actual access to early intervention. I think that with the early diagnosis can come the advocacy then for earlier intervention. I can speak to our specific center in that now that we are making some of these diagnoses, most of our diagnoses are coming at less than 6 months of age, many at 3 months of age. We have very specific pathways with our treatment centers and referral partners that enable access for this particular reason. So we will actually kind of send that referral. We have a pathway for referral, get on the phone to our referral partners and make sure that we harness that neuroplasticity. So I think it's coming. And some regions may need more support in that. But I think now that we know that we can make a diagnosis early, that we can potentially harness this neuroplasticity with early intervention, that I think our next step is in advocating for the actual services in the community, which can be a little bit more difficult, but absolutely doable, because we have established a process for that within our community here that serves McMaster.
And I feel like many communities can follow the pathway, because we know families who live in remote areas, in reserves, the access to care is not the same as families who live in the big cities. I think there will be a lot of work needed to introduce your pathway to all these other areas in Canada, because it's such a vast country. But my question to you is, because now we know that not all neonatal follow-up clinics in Canada, they see babies that for 30, 31 week babies. Some, the cutoff is 26 weeks. And then they hope the pediatrician in the community will follow up with those babies and deliver the diagnosis. Are they also going to be involved in this early identification of CP? What is the Canadian Neonatal Follow-Up Network doing to also build capacity on the community professions to do this early diagnosis and have the kids referred, the babies referred to services and other services in the community?
Yeah, we have started doing that with our Hammersmith Infant Neurological Examination Implementation and Teaching team, where we host webinars fairly frequently in the actual approach to administering and then interpreting behind that assessment in neonatal follow-up and in children up to 2 years of age. So this is accessible to any clinician that would like to access it, and it's outside of the Canadian Neonatal Follow-Up Network, so it's not specific to the tertiary level NICU neonatal follow-up clinics. If anyone wants information about that or upcoming webinars, typically they're hosted on the Holland Bloor View website, or the information can be found through there, and the Hammersmith Infant Neurological Examination resources that they have there. So we've started doing some of that outreach, but I think there's definitely way more work to be done to allow that to be more accessible to centers outside of tertiary level care.
Because in the neonatal follow-up, you have this multidisciplinary team, right, to provide the test and the diagnosis. How does it work in the community when there is not a multidisciplinary team? You rely maybe in one physician or one therapist.
Yeah, so most of the assessments that we can do now, primarily the HINE, is something that can be done in a few minutes with some training by pediatricians in the community, and can be done as early as 2 to 3 months of age. So that is something that can be done then and followed sort of over time. So absolutely, that's something that can be done without need for access to all of the multidisciplinary care. Certainly having access to all of those resources is a huge bonus, and provide support to clinicians, to physicians, to families. But it's something that can be done without all of those additional specialists involved.
That's great to know. And for everyone listening to us, you have lots of tools and information on. I know the Canadian Neonatal Follow Up Network, they get in contact with the follow-up networks, but also the Can Child and the CPNet websites have a lot of information on those tools. So my next question to you is, because last week, actually, we had this happen in our private parent group. One parent posted that the baby, I don't know where in Canada that baby was, but was a higher probability of cerebral palsy. And now the baby is 15 to 16 months old, developing according to the schedule, reaching all the milestones. And this mom posted, should I still expect the CP diagnosis? And I saved that comment because I feel it's an important concern to address with parents, because we are not standardized yet, right? So what do you say to those parents or to your colleagues so that this situation can keep showing up?
Yeah, and I think that this is something that there is a lot of discussion around, is giving the high probability of CP diagnosis, and ensuring that we emphasize uncertainty. And I think being completely honest and direct about that with families is what's going to be most important. I think it's important for families to know if there is sort of evidence that early intervention may be helpful. But I think that emphasizing the uncertainty within that diagnosis is especially important. As we start doing this and hearing more from families is the only way that we're going to know how to do it better. And so I think that that's something that we just need to continually reflect on as clinicians and as a bigger a group at large that is working in this sphere, is actually getting a sense from families as to what the impact of hearing that when there is a lot of uncertainty for some families, and in some cases, when you give a high probability of CP diagnosis, there is quite a bit of certainty just when reviewing their medical course, neuroimaging, current assessment, and you can be more certain in that moment. But in many families, especially in our babies that are born extremely preterm, where some of the assessments may have scores that are reflective of a higher probability CP, I think it's especially important to just really emphasize uncertainty, be honest with families, maintain that hope with families and clinicians that are around you, and just reflect on this as a group on an ongoing basis. And we do plan to do that in a few different ways as well.
Okay, so my question to you is, when you talk about uncertainty, can you clarify to families, what does that mean to have uncertainty? Because we don't see necessarily, I'll see that your baby, didn't lift the head, or is not sitting, or is not reaching out, for objects. But what does that uncertainty mean? Does it mean they might continue to develop and not show more signs of CP? Does it mean the gross motor functional level is going to change, or is going to be more evident as the baby grows up and go into the toddler years? I just wanted to clarify that, because for people who are very early in this journey, it's very difficult to understand, and also that is not a progressive condition. And I think I would like you to touch a little bit on that for families.
Yeah, so CP exactly is not a progressive condition. It is a diagnosis that a child either has or does not have. And in the context of this high probability CP, this is when we're looking at babies that are like 3 months, 4 months of age. And when we're talking about high probability CP, we should be taking into context things like neuroimaging, their course in hospital, but some of the assessments that we do can lead to scores that put a baby in a category of high probability CP. Some of the things contributing to that score might be things that we often just see in babies that are born preterm and not necessarily specific to a diagnosis of CP. So for example, a baby that is born very early might have quite low central tone, might not be kind of as sturdy as we might expect at that 3 to 4 months corrected age mark, and that's totally fine, but may benefit from some additional support. And when looking at a score that's received on an assessment may fall into a category of high probability CP because of these different things that don't actually translate later to a diagnosis of CP. So that's why I think it's very important for clinicians that are communicating this to be aware of that and not use some of this language when they when it isn't very clear or when the kind of findings might be explained by something else.
Okay, that is a great information. And so you talk about neuroimaging, and we know not all NICUs in Canada, maybe very few have an MRI in-house, or sometimes had to transport the baby to do MRI. So what is your take on the MRI specifically? Because we know that ultrasounds are not as precise to see the brain damage. My son had a PVL, a brain injury. My son had a PVL that was not picked up in an ultrasound. It was not only after diagnosis, we had an MRI done. So where are we now in Canada with the MRI and neuroimaging general to confirm maybe a diagnosis, or maybe to, okay, this baby is a higher risk, even though there was no other signs. So I think that is a moment when a lot of NICUs are looking to have an MRI in-house. So what is your take on that, and what is happening across the country?
Yes. So I think depending on who you ask, you might get a different answer. But the MRI findings or neuroimaging findings are not actually going to change our management or plan or intervention strategy for any particular infant. If an infant has had a course that is in keeping with a higher likelihood of diagnosis of CP, then neuroimaging is not actually necessary. It's not kind of one of the predefined criteria that's necessary for a diagnosis of CP, and CP is a clinical diagnosis. So you do not need to have any neuroimaging. It can be helpful in delineating sort of the pattern of injury and that kind of thing. But if I were to have, for example, a child that I were to see in neonatal follow-up who has a significant history of extreme prematurity and potentially other morbidities in the NICU, and they later go on to have assessment findings that are in keeping with CP, I would not recommend further neuroimaging for those children, because it's not going to change anything that we do or any management strategy. And often in babies, depending on the age at which you're seeing them, will need general anesthetic or some sort of anesthetic for an MRI to be completed, which comes with another host of potential risks. So I lean towards neuroimaging, unless, of course, I'm seeing a child that does not have a history that may be in keeping with that likelihood, and I'm looking for other potential causes.
Okay, thank you. So before we wrap up our session today, do you have any message to parents who are listening to us today, or healthcare professionals? We have a few from out of Canada. First, I think for parents, when they are either first diagnosed or maybe have a just higher probability of CP, what would you tell them? And your colleagues that are not necessarily in Canada listening to us today, what do you recommend to them when it comes to the time of diagnosis or talking to parents? Because you have so much experience with that in Canada that I think a lot of people we can learn from each other around the world.
Yeah, for parents, I think I always recommend that they ask questions and just keep asking questions and advocating for your child, because you will be your child's best advocate, and that's sort of what I recommend to all of the families that I see in our clinic. For clinicians, it would be sort of on the other end of that, is listening to families and the information that they want to know, the information that they already know, and ensuring that they've heard the information in the way that you had wanted to translate it. So I think a lot of my take-home messages would be around communicating and communication on both sides of that equation.
This is always the key. I always talk about how we communicate with families. It can put us in a different trajectory, right? As I love when you talk about the values, like do not put your values, be neutral when you're giving any news to families, because you can set us on our very good trajectory that we see hope and you're going to work towards something, or you're going to live in completely fear of the unknown, all these uncertainties that the future holds for our children. And I think communication is the key. And as Desiree said, the support she always had from healthcare providers made a difference in her life, and it does make a difference in our lives as well as parents. So thank you for working on this. I think we know change is hard. There'll be resistance. There's a lot of education to be done across Canada, but I'm so grateful that you are doing this work and you're doing so well with families. Always incorporate families' values and preferences in all the work that you do. And so I'm really grateful and thank you for joining us here today as we raise awareness of CP this October.
And thank you for having me.
And to all of you watching us live today, thank you for joining this Preemie Chat, and a special thanks to our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder that if you missed part of today's session, head over to canadianpreemies.org to see this episode and all past sessions of our Preemie Chats. And just you're also going to reminder there that many resources and supports are available to families. And we are a charitable organization and we depend on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all babies and their families. And we'll be back next Friday, 1 p.m. Eastern Time. Stay well.